Hello, and welcome to another episode in our series about the history and continued evolution of RxP, Prescriptive Authority for Psychologists. I am George Kapalka, Program Director of the Master of Science degree in Clinical Psychopharmacology at Alliant University. In this series, we focus on the major developments in the RxP movements from its inception to the present. Today, I am especially thrilled to talk about the Department of Defense Psychopharmacology Demonstration Project, which trained psychologists working within the military to obtain prescriptive authority within federal sites. We will talk about the format of the training, the students, educational methods, graduates, and the impact of this training program on the evolution of RxP, as well as the dynamics that eventually led to its dissolution. Joining me today are two graduates of the program, Dr. Anita Brown and Dr. John Sexton. Dr. Anita Brown lived and practiced in Pittsburgh for 19 years and had experience in working with military veterans. When she was president-elect of the Pennsylvania Psychological Association, she learned about the PDP training program and became a strong supporter. Her leadership positions in PPA then led her to executive positions in both the practice and education directorates at the American Psychological Association. From 1991 to 1994, she participated in the development of APA's guideline for psychopharmacological training for psychologists, and she provided collegial support for the first two cohorts of the DoD Psychopharmacology Demonstration Project, the PDP. She enrolled in the third iteration of the training and completed a total of 5 years of Army service. She progressed to the position of Chief of Mental Health, 4th Industry Division at Fort Hood, Texas, as an independent prescriber. After leaving the Army, she continued to prescribe independently in military settings at Fort Eustis, Virginia, and Landstuhl Regional Medical Center in Germany. An early leader in APA Division 55, which is now the Division for Prescribing Psychology, Dr. Brown testified in states for legislative authority for psychologists to prescribe, developed the initial didactic curriculum for the postdoctoral training program at Fairleigh Dickinson University, which was modeled after the PDP curriculum, and participated in item development for the early versions of the PEP. Currently, she is Director of Professional Affairs for the Georgia Psychological Association and member of the APA Ethics Code Revision Task Force. Welcome, Dr. Brown. My second guest is Dr. John Sexton. Dr. Sexton graduated from the U.S. Naval Academy in 1972 and was a Marine Corps officer for 11 years. He became a Navy clinical psychologist in 1983 and served in varied assignments around the world. Dr. Sexton was one of the first two graduates of the DoD program, in which he completed approximately 75% of the medical school courses at the Uniformed Services University School of Medicine and a one-year residency at Walter Reed Army Medical Center. Following the fellowship, Dr. Sexton was assigned to Naval Medical Center, Portsmouth, and in February 1995 became the nation's first independent practitioner prescribing psychologist. He continued to serve as a prescribing psychologist with tours at 2 naval hospitals in California before retiring after 32 years of service as a naval officer. From 2004 until he again retired in 2011, Dr. Sexton served as a staff psychologist at the Counseling and Psychological Services of the University of California, San Diego. Welcome, Dr. Sexton. So the PDP program was something that so many of us first entering the RxP movement in the mid-1990s were aware of. But we really did not know many of the details, many of the actual educational approaches and how the program actually worked. So I'm really looking forward to learning a tremendous amount about what that program was like. And then, of course, we'd love to chat a little bit about the impact that this program has had on the whole prescriptive psychology movement. So here's a little bit of the history of the PDP. So in 1988, congressional conferees direct the U.S. Department of Defense to establish a pilot project to train psychologists in issuing psychotropic medications under certain circumstances as part of the fiscal year 1989 appropriations bill. In 1989, APA's Board of Professional Affairs strongly endorses immediate study and the feasibility of RxP and appropriate corresponding curricula in psychopharmacology. In 1990, APA's Council of Representatives approves a motion in an 118 to 2 vote, which is very, very significant, to establish an ad hoc task force in psychopharmacology. In 1991, the first cohort starts in the PDP program. In 1992, the APA Task Force on Psychopharmacology issues a report to Council concluding that practitioners with combined psychosocial and psychopharmacological preparation could advance treatment and, in accordance, men's multi-level psychopharmacology training. So since 1989, as this is happening, the PDP program is already in effect. In 1994, Commander John Sexton, PhD, and Lieutenant Commander Morgan Salmons, PhD, and the first two graduates of the DoD program. And in a direct line, in 1998, the first MSCP program takes off at the California School of Professional Psychology. And just like the training at FDU, our program was also patterned in large part after the training of the PDP program. So I'd like to open with this question. How did you both initially become aware of the PDP program?
I fell into it when I was coming available for my postdoc fellowship. In the Navy's clinical psychologists could go off and do 2 or 3 tours at various hospitals or units, and then ask for a postdoc fellowship in child psychology, neuropsych testing, or health psychology. And health psychology interested me the most, so I asked my detailer if I could have one of those slots. And he said, well, we don't have those now, but what we do have is a program that's very close to it. Yeah. Take a few classes at the Uniformed Services University and then go to Walter Reed Army Medical Center and prescribe some psychotropics. Well, it was far beyond that we had to endure. But that's how I found out about it. My detailer or officer who makes the assignments tricked me into coming aboard.
And for me, it was as president-elect of the Pennsylvania Psychological Association, we were asked to sign on to a document that endorsed and supported this program. And I thought, well, yeah, that sounds like it makes a lot of sense. And as I traveled back and forth as president-elect and then president of Pennsylvania Psych Association to APA, I fell into the position of assistant executive director for policy training and research in the practice directorate. And one of my first assignments was to mentor and offer APA's support to the then 4 first cohort of the PDP. And of course, John and Morgan Salmons were 2 of those who completed that foursome. I think the third person went on to medical school to become a psychiatrist, and I'm not
Yes.
sure what happened to the 4th person. Maybe John
He
remembers.
just bailed.
Okay. So by the time I got to APA and began helping to support the first and second cohort, which was that James Meredith, I think? We were quite familiar with each other and with the program. And so in the 3rd year, when no one from the Army was volunteering to join this program, I said, what the heck? I'm an Air Force brat. I could do this. And Deborah Donovan and I both entered the military direct accession to enter into the PDP program in the third cohort, along with 3 other psychologists who were already active duty in the military.
What drew you both to psychopharmacology in the first place? How did you happen to have an interest in that particular area?
I had no interest in the area. That wasn't my forte. I had other plans for my career, but it grew on me, and I learned to love it.
To the contrary, my career at the University of Pittsburgh had been initially as an evaluator for the NIMH Collaborative Treatment of Depression study, which looked at interpersonal therapy, cognitive behavioral therapy, a placebo, and imipramine, which was the drug of choice at that point. And as a clinical evaluator, I was supposedly blind to the treatment paradigm that each patient was being treated with. But after a while, I began to recognize some of the side effects of imipramine on the patients, and my interest just continued to grow as I worked in a number of medical settings, including VA postdocs and internships. So it was always lurking there in the background, that little bit of knowledge that I had about the meds that patients that I was treating were taking.
Thank you. Tell us a little bit about the training program itself. So I'm kind of curious, what was the training structure? How were classes held? Did you first complete classes and then did the usual internship rotations that are in medical school? Tell us a little bit how the program actually worked.
My classes at University USU were alongside medical students. These were students typically right out of college, young enough to be my children, who had done a lot of pre-med work. I remember the first we were welcomed to USU by the dean, and then he said, "And we're going to jump right into your first class, which was biochemistry." And the professor walks on out, holding up the textbook by Voet and Voet, which is the classic work. And I remember him asking, "How many of you have used this textbook?" And about 95% of the class raises their hand. So I turned to one of my Army buddies who had just finished up part of PA school. And I said, "Biochemistry, is it?" And he says, "Well, that's what you take after organic chemistry." I said, "Organic chemistry?" The last chemistry course I had was at the Naval Academy in propulsion chemistry. And so I thought I wasn't in a place to do very well, but took a lot of study. Classes were in that large theater sort of experience, something you would see in colleges with 175 students in the class. You were lectured to, and then you went to the lab often. But that was the first 2 years of medical school, which is typical for medical schools. There are some that do a whole lot of hands-on patient care involved in their learning in the first couple of years. But most medical schools are strictly in the classroom and the lab for 2 years. And then you go off and you do your rotations in neurology, pediatrics, cardiology, and so forth. It was a demanding 2 years in the classroom. And then the third year was our opportunity to do hands-on clinical work, mostly with psychiatry patients, but we also worked with cardiology and neurology and so forth, brief rotations.
So how big was your class? Because it sounds like the first PDP class was 4 of you at the time. How many medical students did you join?
About 170, 175. Yeah. We sat in the back of of this large stadium sort of seating, and they would look up at us often thinking, "Gosh, what our grandparents are?"
What are they doing here?
Yeah, what are they doing? And they were all young lieutenants, butter bars, and here we were, commanders and and majors. And yeah, it was a different sort of experience. Yeah.
Well, I will interject that my trajectory was quite different. By the third iteration, the American College of Neuropsychopharmacology had a contract to track our progress throughout the years of the program. And I think by that time, the third iteration, they had decided we really did not need quite the same experience. So we went to U-Shoes for 1 year. In the summer of our preceding that first year, we took crash courses in biochemistry and neuroanatomy and physiology, which included dissection of a cadaver. We were also cohorts to a class of nurse anesthetists. So instead of having strictly medical students as our companions, we had nurse anesthetists who also were going through sort of a introductory course. Our training at U-Shoes was only 1 year. So then we took the routine rotation of medical school courses that second-year medical students were taking, and anatomy, physiology, pathophysiology, etc. And we also did some, I don't know what they're called in medical school, but we would, with a group of other students, and we would sort of do rotations and classes. And all of the classes in mental health, of course, everybody looked at us to give them the answers. The rest of them, we were sort of leaning on each other's shield and making up mnemonics about everything you could possibly think of to get through. We did take the medical boards at the end of our year, and many of us surpassed the scores on the medical boards of the medical students simply because we had a lot of experience. So at the end of 1 year of concentrated studies, we went into the second year, which was a 6-month rotation in an inpatient setting at Walter Reed or various hospitals in the DC area. I was at Walter Reed because I was Army, and a 6-month rotation in the outpatient clinic. I will say that Dr. Olashansky, who was our medical psychiatry mentor, was right there by our side all the way through, Marv Olashansky, and he really did nurture us and let us know that we really could do this. And so as the third cohort, we completed all of that academic background in 1 year, and the second year was 2 6-month rotations.
And how big was that third cohort?
It was the largest cohort. It was 5 of us. There were 2 Army, 2 Air Force, and 1 Navy.
And also about 150 or so medical students?
Oh, yes, easily. But also we did some of our classes, as I said, with nurse anesthetists who were all military, but coming back to finish a master's degree so that they could go on and do clinical practice.
Tell us about your colleagues in the program, especially the medical colleagues. What was the reaction of these medical students to having psychologists in the program? And also, what was the reaction of the faculty that are now seeing psychologists among their medical students taking their program?
Well, John paved the way. By the time they got to us, I think they really appreciated us. But John, I think you have better stories to tell.
The students, again, half of my age, or young enough to be my children, sort of looked up to us as experienced military people. But they knew, as well as the faculty knew, that that most of us were not prepared for medical school. And some, put their hands out and gave us support. Professors were a mixed bag too. Some of them knew that we were not ready for such an experience and helped us a lot. But in general, it was throw you into the stream and you sink or swim. And it was tough for most of us. The 2 that did most of PA school were much better prepared than Morgan Salmons and I, who were coming in cold.
And just to be clear, I think the 2 who had done the PA school had a year before Morgan and John for a cadre of 4. And one of them decided that he was going to go to medical school and become a psychiatrist. So in your year group, I think 2 out of the 4 of you completed. I don't know who was with Jim Meredith in the second year, but he was the only one who completed the second cohort. In the third cohort, all 5 of us finished And in the fourth cohort, there were, I think, 2 or 3, and both of them, I think, completed the program. But there were 10 of us who graduated from the PDP altogether. And it was a pilot program. It was not meant to become a consistently given program. After 5 cohorts, I think they said, yes, this can be done. And the rest is history.
What were the biggest challenges the two of you faced in completing the program?
Well, the academic rigor that was needed. Yeah, I mean, we were competing against the medical students for passing the course. They set the bar high. That was the most demanding aspect. Rotations were fairly easy for us in that we'd been doing patient care for so long. It was easy for us to adapt to that aspect. The didactic material, the 6 months of full body dissection and so forth were not things that we had planned. Of course, dissecting the hand and identifying the 100 structures and insertions was important because you put the pill in the hand before you stick it in your mouth. But so we found
It was a
ways.
standing joke with us.
Yeah, we found ways to tolerate the program.
And I think for us, by the time we got there, I mean, it was really only 1 year of in the classroom experience. Many of us had worked in medical settings and kind of knew some things. The 6 months inpatient, 6 months outpatient was also a little bit familiar. It was more, I think, the indoctrination and doing full physical exams and touching our patients, for the first time was
Yeah,
different.
that is different for psychologists, right? Yeah. Yeah. So, yeah, I was kind of curious. Did the medical students finally warm up to you guys and kind of accept you as your own? Did the faculty ever try to trip you up like you don't belong here? That kind of approach.
Faculty were supportive. Some, really extended themselves to help us, knowing that we were not well prepared. Yeah, we and the 4 of us were on the same cadaver for the 6 months, and we had a cadaver that had such mysteries and provided such interesting things to us. The other tables around us doing dissection would come on up and want to talk with us and see our finds. So it was generally good with the students and generally good with the staff.
And as I said, by the 3rd iteration, we didn't have much of any of the rigor really that John and his cohort and the one behind him went through with 2 years at USHUS. Finally, I guess ACNP also said this is a little bit of overkill, no pun intended, for these folks who have, many of them, been practicing for 5 or more years as doctoral levels providers. It was a lot easier to narrow it down to 1 year of didactics and 1 year of inpatient and outpatient work. And then we were done and off to our various locations.
Did the program enroll annually, or was it an irregular enrollment in terms of how frequently the classes started?
It was 4 cohorts, I think, year after year.
Year after
So-
year. And what was the length of the program?
Ours, the first iteration was a 3-year program, and then
Everything after that was 2 years.
yeah.
And then what else did you both have to do to actually start prescribing?
Well, we needed to get the privilege to prescribe at our various institutions. I mean, we were prescribing right there at Walter Reed, finishing up our training, much like what a resident does. But after, when we went to our first real duty assignment, we had to get privileged to prescribe. I was licensed in North Carolina at the time because I had been there in one of my earlier assignments. The American Psychiatric Association tried to come after my license in North Carolina because they thought I was practicing outside my scope of training. I mean, that made it a little bit difficult, but I fought really hard, presented lots of information, and it took me about 8 months to get the privilege totally signed. Up until that point, I had a psychiatrist who was quite skilled. She did want the job, but she was ordered to have the job of supervising me. And simply what she did was to look at my charting after I had seen a patient and done a physical and everything. She would look at my charts and approve them or not. But I think she approved everything. So that was my first assignment at Naval Medical Center, Portsmouth. So 8 months of that until I got the thumbs up that I was an independent practitioner. And I wrote that script on February 10th, 1995 for sertraline for somebody who I had been following and my charts were being reviewed, but a nurse at the hospital, I wrote for her to have an increase in her sertraline. And yeah.
So when you started prescribing, were you actually completing your residency?
Residency is not a term that we used. We were doing rotations at the PDP program out of Walter Reed. I was just an outpatient provider at Portsmouth in psychology. I was in the psychology department, but a psychiatrist oversaw my charting.
So you didn't have to do the standard residencies that people normally do after medical school.
No.
Right.
And
Yeah,
we were
yeah.
mostly credentialed. I went
Yeah.
straight to Fort Hood after I went to Officers Basic, the 2 years into the Army, but I went straight to Fort Hood and got credentialed. We were always credentialed as psychologists. And based upon our doctoral degree and experience in psychology, that's who we were. We just happened to then have to get privileges to prescribe in that particular setting. I went to Landstuhl, I went to Fort Eustis. I was hired as a clinical psychologist, but I had the credential to prescribe along with that.
And maybe we can talk a little bit about that, because I think a lot of people to this day are kind of curious about how that works, that you can potentially prescribe within federal sites, but it really is decided on a case-by-case basis.
Yeah, the commanding officer of the unit, typically the hospital, as is true of all military units, they have ultimate responsibility for what goes on in their unit, the hospital. So they have a credentialing board that examines all that it is that you present, your training and experience and so on and so forth. We had to fight that battle with each move. It became easier. I can say, look at that. I prescribed for 2 years there, 3 years here. But we still had to fight that battle because they weren't prepared for a psychologist to come in and ask for the privilege to prescribe.
And by the time I finished my military duty at Fort Hood, I left the Army and left practice to do 3 years in an academic setting, 4 years, I think it was, all told. And then I went back to work as a civilian for the Army at Fort Eustis. And my best friend was the chief of mental health. So, of course, he petitioned for me to have the credential as a civilian doctoral level psychologist to prescribe at Fort Eustis, McDonald Army Medical Center. And then from there, I went to Landstuhl Regional Medical Center, where I also continued, after having gone through the process, to be credentialed to independently prescribe medications as a civilian psychologist. Most of my prescribing years were done as a civilian, but as an employee of the Army.
So that's still the process that's going on today. Maybe it's gotten a little bit easier at some sites that already have some experience with prescribing psychologists, but it's still very much up to the discretion of the base commander and the credentialing board that happens to function at each individual site, whether or not they're receptive to the idea of psychologists prescribing, how heavily they may be influenced by organized medicine or psychiatry. So this is why it can be so unpredictable. You cannot assume that every federal site will
And I guess it's really the hospital commander, the base commander probably has little to do with it, but the hospital commander would be the person who would decide. And who you could prescribe to. Can you prescribe to civilians? Can you prescribe to children? Can you prescribe to geriatric patients who might still have medical treatment at a military medical treatment facility? So it really could vary dramatically between military sites.
How did this training, completing this program and becoming a prescriber, how did that affect your practice from that point forward?
Might be a good segue into my top 10 ways prescribing changed my practice. Prescribing changed the way I look at people. People might say, the way you look at people. Well, I look at hair thickness, skin tone, breathing rate, thyroid size. We were trained well to examine the person, not just what they're saying, but look at every aspect. It changed the frequency in which I had follow-up visits. So as a psychologist, the average psychotherapy patient, you would see them once a week, maybe once every other week if the schedule was demanding. But I would see my medication patients typically a couple times in the first week, and maybe even the second week, but then I would stretch out the amount of time based upon their response to the medication and the talking, and found that to be quite good. I mean, there were times where I had 70, 80 patients that I was following, but I could do that with some patients who were good and compliant with their medication and responding well. Prescribing meant less time tracking down the MDs for assistance. It made psychotherapy easier. My depressed patients did their homework because I was good at assigning homework. They talked more. My anxious patients were more available, and my manic and psychotic patients were able to hear me. Yeah, the prescribing made psychotherapy a lot easier. Prescribing caused me to better inform my patients. I quadrupled the amount of time I spent doing informed consent. Prescribing taught me to catch the very important psychological masquerade. I knew a lot about substance abuse, but I would very much tune in to everything that a patient was putting in their body. So off-label drugs and illicit drugs. But I mean, I had patients who were psychotic or manic because they were taking too much Afrin or caffeine. I had a Olympic bench press guy from the Army who was psychotic because he was taking too much caffeine. It's hard to do drinking coffee, but you can take a whole lot of pills to make yourself that. To get him on the ward at Walter Reed was really tough. We had a whole team. Prescribing helped me reach the underserved because I went where psychiatrists were absent. I went to the AIDS clinic. I went to the pain clinic, went to the prisons, the Brigs, to treat my patients. Prescribing helped me improve healthcare in general because I often unprescribed and I applied meds as an adjunct. I titrated those meds to go along with the success I was having in psychotherapy. I did an informal study, which the Navy wouldn't allow me to publish. I was the head of mental health at Camp Pendleton. We examined the prescribing rates of the two psychiatrists who worked for me and my prescribing rate. Patients were randomly assigned to us based upon our on-call day. They prescribed to 61 and 68% of their patients. I prescribed to 13%. Prescribing allowed me to exponentially improve patient care by way of teaching and consulting. I taught psychologists, family practice residents, consulted with primary care managers, because there is a substantial behavioral component to those patients seen by primary care managers in their clinic visits. 75% of all primary care visits have a emotional behavioral component to it. I really liked how prescribing changed my practice, and then how I could help other clinicians do better work for our patients.
I think I realized how much 2 prior experiences had prepared me for prescribing. One was the NIMH Collaborative Treatment of Depression study, where as a clinical evaluator, I was supposed to be blind to which treatment condition a person was in. But if you're seeing someone every 4 weeks, every 6 weeks, you can tell if they're taking medications based upon, sort of smacking your lips or being thirsty or gaining weight. You can tell when they're getting better and when they're not, and sort of think about some of the reasons. I went from there to treatment, cognitive behavioral treatment of chronic pain setting, and was treating patients who were often on a multitude of meds, some of them psychotropic, some of them with psychotropic effects. And you had to integrate that into having them work with you in a cognitive behavioral or relaxation training or whatever kind of fashion. So all of my internship and my previous jobs had sort of led me quite naturally to supplementing my care with medications and knowing when to titrate up, when they needed medications, when, they needed more other kinds of treatments. And I think it just made me better as a whole psychologist to have that in my armamentarium of things that I could use or could not use. And also to ask them, are you taking your meds as prescribed? Because oftentimes, 9 times out of 10, they are not taking the prescribed meds in the manner in which they were prescribed. Oh, I feel depressed today, so maybe I'll take my antidepressant.
Right.
No, that's not quite the way it works. So I think it just made me better as an all-round provider of mental health care to have that at my disposal and to have the knowledge of it and access to it when I felt it was needed, and to try titrate up, titrate down, change meds, because I'm seeing you more frequently. I'm not giving you 90 pills and saying, come back and see me in 3 months. And, oh, you might have side effects, but maybe, it's just the way we treat patients is enhanced by having that as a tool, I
And
think.
I was struck by the way you both described it. You used somewhat different words, but I think the meaning and the message was the same. So you started to supplement therapeutic intervention, psychotherapeutic, with adding medication management rather than supplementing medical management with psychotherapy. And that's something that I think so many people who are not familiar with the practice patterns of prescribing psychologists, I think their fear is that we kind of just become like a junior psychiatrist, someone who just sees people for 5-minute medication management sessions, and we essentially give up all the training and all the techniques that we've always used as psychologists. And a lot of the data shows, not only from what you just said, but some of the research by McGrath and colleagues, and more recently by Hughes and colleagues, that really shows that psychologists, once they start prescribing, they continue to utilize psychotherapy. They just add this as a tool. So you both verbalized it so strong. And it's so interesting that since you guys were really first prescribers in the country, right? We're talking about mid-1990s, already that approach was there in how you were conceptualizing it.
We had long histories in doing psychotherapy. We knew it well. We knew the advantages. We just added this other tool to our toolbox, as opposed to psychiatry, where they only have a hammer in their toolbox and everything looks like a nail. So that's just medication first. If that doesn't work, well, maybe they'll ask a couple questions.
Yeah, everything else is an afterthought, right?
And importantly, too, we know how to talk to our patients about medicine. I mean, if you're not sleeping, then you need to sleep. And it led me to further study about sleep hygiene. So if you're not sleeping, if you're suicidal, there's certain things we can do to sort of help that immediately, and then we can start talking. Or you just learn how to titrate your treatments differently, I think, when you have more tools at your disposal.
Talk a little bit about your thoughts about the impact of this demonstration project and the progression of RxP?
I think one thing that it did was to show us that we can add this tool and not change our identity as psychologists and the way we were trained. It's just one other thing that we can use. And I think that it also made us even more aware, especially if we weren't health psychologists or neuropsychologists in the first place, about the interrelationship between the brain and behavior. Sometimes you don't need to talk about things. You just you need to alter the brain chemistry so that you can talk about things in a more productive way. So it gave us another tool and a better way. It gave me a better way of understanding all of the components that go into trying to help improve our skills and make our patients better.
I enjoyed work with challenging patients. That's the reason I worked with the Briggs and the prisons and took on patients who were floridly psychotic or panic. I had the opportunity to prescribe to them and get them calmed down. One who was to leave Camp Pendleton within months after I had left Camp Pendleton myself, but he was not going to Coronado where I am. He was going to Leavenworth, and he was going to be put to death because he murdered his XO and shot his CO. And he was feces smearing psychotic when I first saw him. I was able to get him calmed down enough that he could participate in his own defense. Not that that was a big thing, but he would have been likely put to death for what it is he did, but he became unpsychotic. And I heard about it in the news like 8 years later that he was not being transferred and he to Leavenworth. He was going to a psychiatric hospital. So the power of these meds can really change lives. And when we have those at our disposal, especially for our psychotic patients and our depressed patients who are suicidal, it just kept me going. I worked long hours and I just loved it to see what was typically a good response.
And I'm reminded of something that Pat DeLeon says, the right to prescribe is the right to unprescribe. So that when you have tools that you can use that are non-medicine tools, we know those as well. And so we can kind of guide the trajectory of treatment, having more tools at our disposal.
Right. And the data again shows that compared with psychiatrists, prescribing psychologists deprescribe a lot more than psychiatrists do. Yeah. There's so many ways I think this program impacted RxP and different aspects of RxP. Maybe the two of you can talk a little bit about opening doors at the federal level for people to be able to prescribe, even in states where the state has not yet passed prescriptive authority.
Well, the VA and what's the other one? The VA and
Prison system.
prison systems are, there are still some places where it's just not happening.
Like where it is happening, it's the military sites, right?
Yes, that's clearly the military.
I guess I'm thinking Indian Health Service, right?
Yeah.
What are some other federal facilities where that is at least potentially possible?
And I think we'll see it go farther and wider as we get more people on board who have those specialties or who treat certain populations. Right now, I think we're pretty much cut off at 18 to 65, although I know in some places people treat geriatric populations. I'm not sure how many people are prescribing for kids at this point. I think I remember hearing someone say it took optometrists 50 years, or it took some profession, I can't remember what it was, 50 years to get the right to prescribe. And I think we're approaching that, but hopefully it won't be quite that dramatic.
So you actually raise an interesting question that I thought about a little bit earlier. When you become credentialed at these federal sites, you mentioned before you may have some population restrictions. Are there also typically maybe some formulary restrictions or usually not?
In the 3 institutions, military hospitals where I prescribed, they gave me different formularies. But essentially, I could prescribe anything that is considered a psychotropic or is commonly used by psychiatrists to treat certain illnesses. Pretty lax in that regard, but sometimes I had to speak up and say, hey, look, this is a common practice using this medication. So,
Yes, same here.
And I think one variable also to keep in mind when we're talking about practicing at federal sites, I think currently what's required is that prescribing psychologists wishing to practice at a federal site, that's like a carve out, right? In a state where there is no prescriptive authority, that prescribing psychologist must hold a prescribing psychologist license from one of the states that currently have it. And then depending on which state they're licensed in, that license may have some restrictions, right? So for example, if you're licensed as a prescribing psychologist in Illinois, you have some age restrictions, you have some formulary restrictions, right? So even if you're not practicing in Illinois, if you're doing it based on that license, then those restrictions apply. If you're licensed as a prescribing psychologist in New Mexico, because our law tends to be broader and more favorable, we don't have these age restrictions or formulary restrictions. So then someone at a federal site who is able to prescribe based on that license then has a broader choice of psychotropics.
Good to know.
yeah.
So now to the sadder part of the interview, because so many of us back then and still in retrospect wish that the program continued. But as you said at the beginning, this was a pilot program which just sunsetted. So tell us a little bit about how that came about, the dissolution of.
We had 2 major examining bodies looking at what it is we were doing. The GAO, Government Accounting Office, the GAO and the American College of Neuropsychopharmacology. They both knew that this was a demonstration project and that we were trying to demonstrate that psychologists could do this safely. And so I found some GAO language. They found that the program successfully trained psychologists to prescribe, though it noted the need for clear definitions of scope of practice and cost effectiveness analysis. So they were looking at that angle of it, that it was designed to be limited. Neither the Congress nor the DoD determined that prescribing psychologists were needed to meet DoD's medical readiness requirement. I guess we have enough psychiatrists or enough of our primary care providers who were well enough trained in appropriate application of psychotropics, but it was determined that we were okay in the military. Of course, there are groups around the country who are sorely underserved. When I was looking at this data many, many years ago, there was one child psychiatrist in the state of Montana that had to travel around. There were lots of psychologists who treated children, and if they could have added a little bit of medication. So the need that exists in rural America, in prisons, with some patients like AIDS patients are attended to pretty well now, but when they were on an average of 6 different medications each, psychiatrists, didn't want to get real close. We filled the need in places that it existed. I think the GAO knew that we could do that, and ACNP said, okay, you've demonstrated it can be done.
Anita, what are your thoughts about the solution of the program and the dynamics behind it?
Well, I think it just requires continued pressure and continued advocacy, continued training. I can't think of a graduate training program at this point that does not include some basic psychopharmacology, at least one course, just continuing to integrate it into practices. But I'm not naive either. I think definitely you need to make it happen. You can't just sit back and continue to train people, but not give them the license to do so. From the work of the committee or the work group, whatever it was at APA, they really did talk about 3 different levels
Yeah.
of psychopharm training. And the third one is the one we pursued, which is the independent. The second is having enough, not everything's shy of independent prescriptive authority, which I think practically every psychologist needs to have. If 9 out of your 10 patients are taking some kind of med, you better well know about it. And if they're seeing you weekly and their psychiatrist once every 6 months, or more likely their family practice
PCM.
physician, 80% of meds are prescribed. I think that's still the stat.
Yep.
By non-psychiatric physicians, then you'd better know something about your patient's meds and be able to talk to them about it freely without breaking the law, and talk to their prescriber and say, hey, you might want to try this, that, or the other, and educate the patient. So I'm all for level 2, where level 3 is not available. And I just think it needs to be standard. And in many graduate programs, at least an introductory course in clinical psychopharm is standard at this point, but it stops shy of what you might need to do to either independently prescribe or consult around prescriptions. So I think that's a route that's undernourished, if I can say that.
And also what I think became clear as you were describing the program is that starting with the very first cohort, John, with your program, it was 3 years, but then it was decided that 2 years was sufficient. And the subsequent cohorts did the training in 2 years. And the 2 years for the type of prescribing that we do as prescribing psychologists was in fact sufficient. You did become well trained. You did not have to do the entire medical school together with all the internships that they do and then a subsequent residency, right? That the model that they came up with for the DoD project is really the model with some modifications that now the MSCPs use, right? Because it is a intensive 2-year training, heavily medical, which really kind of focuses on the aspects of medicine that are most relevant to psychiatric prescribers, right? Not prescribing psychologists. So I think that's another huge influence that the DoD program has had on the training of prescribing psychologists, period.
And I think another aspect of it, regardless of what you want to do, just a good clinical interview that focuses on medical health, physical health. We're treating whole people here. And it still amazes me the number of people who will do a clinical interview and say, oh, well, I don't know what meds they're taking, or you really do need to know that at least once and then follow up. So it has something to do with sort of just the ground level assessment that we do and how that impacts what we're treating.
To what extent do you think elimination of the program had to do with pressure from medicine saying these folks are getting too close? These folks are showing that they can do a type of medicine without going to full medical school. That's dangerous for us as a profession.
Yeah, I've testified before legislatures of half dozen states, and invariably there'd be a psychiatrist or other paid physician to come and say, you don't have the knowledge of patients. You can't be doing this safely. And it is an issue.
And yet there are many non-physician prescribers these days.
Yes.
Clearly they have a medical background, nurse practitioners, VAs, etc. And if you're a VA patient, it's pretty rare that you do see an actual MD provider.
Yeah.
So a lot of the work that, in certain settings is done by non-physician providers who have full prescriptive authority. Now, clearly they have a medical background, if you want to call it, if you want to classify it in that way. But a fair amount of our health psychology and neuropsychology undergraduate and, more importantly, graduate training is heavily focused on physiology, anatomy, biochemistry, and other things that are key components to the practice and the study of medicine.
And John, you mentioned a few moments ago that when they were deciding to close the program, they identified existing resources, for example, primary care medicine, which can handle some of these cases. But even within primary care, so much has been written about the fact that that's not the best use of primary care professionals, right?
Yeah.
Not only is it then taking up slots that they should and they prefer to devote to patients within their normal scope of practice, but also that they don't have some of the more advanced specialized knowledge that a psychiatrist or prescribing psychologist does have after completing this training. The organized medicine's answer seems to be let's overutilize primary care professionals, whereas that's really not the best use of their time.
Nor do they have the mental health training. I
Right.
mean,
Yes.
just because you give people pills does not mean that they are taking them,
Yeah.
whatever that pill is for.
Yeah.
And primary care professionals, they tend to have a more restricted formulary in terms of what they're comfortable with. There are psychotropics that they will not prescribe. So they're definitely not really in the same position to provide the depth of mental health care that someone like a prescribing psychologist can.
I did some teaching at 2 different family practice residency programs, and the one allowed their family practice residents and staff only 11 minutes per patient. So skilled at making a quick assessment and applying appropriate medication is tough in 11 minutes.
Definitely. Well, this was a fascinating talk. Final thoughts about the program, its impact on prescribing psychology.
I was thinking, what sort of resource might I suggest? Because we want to give homework assignments always. What sort of resource? And I thought of one that's a little bit on the edge, but it is one that helped me immensely, and I used it to do some teaching on it. And that is a book by Robert Taylor called The Psychological Masquerade. And in that book, he cites 7 studies with an N of well over 4,000 patients who entered an outpatient mental health clinic for a psychological problem. 15% of them had an organic basis for their disorder where they thought it was a psychological disturbance. So it's good to have some knowledge in your pleasure reading about medical things that complicate the picture. I think all psychologists would profit from, and their patients would profit from them looking at that subject more.
And I would say that as we progress towards finding different levels of training for people who call themselves psychologists, I think we need to continue to push the field up and incorporate things like knowledge of medicines, like psychopharmacology or other more complex, I guess, areas of learning that warrant a doctoral degree in psychology. There's plenty of work to go around, and so if we're spreading the base, then we need to make sure that if I get that doctorate, I do have some specialized skills that I can put to good use, because not everything in the world of mental health is simple or straightforward. And we need to continue to do the research and incorporate the research and know how to consume research as well as produce it, and just have a whole armamentarium. Is that the second time I've said that word in this? A whole toolkit of things that we can use with knowledge and not just throw pills around or throw techniques around. Or human behavior is complex, as we all know, and so we need a lot of things.
Something I'm thinking about as you're saying it is that Psychology as a profession has experienced in the past couple of decades very significant encroachment upon us from master's level professionals, right? Who, for the most part, do most of what we do, at least when it comes to psychotherapy, right? So a normal evolution of a field of psychology would be to add additional skills in additional areas that master's level professionals really don't have background training and skills. And in psychopharmacology is one of those possibilities, right? And like Anita, like you mentioned, you don't necessarily have to become a prescriber, although if you can, there's pathways now for you to do that. But psychologists can certainly expand their toolbox by learning a lot about psychopharmacology, but by maybe, you know, getting training up to the level 2 of, of of knowledge that allows them then in a more informed way to work with patients and clients who are on medications, and that's such a large proportion
Correct.
of our patients now.
And I think the other thing that we do as psychologists, we do measurement. Let's assess our progress. Let's just not see you for 50 weeks and never have a metric that says, okay, you move from here to there. And so I think most of us in our doctoral programs learned assessment, or learned at least how to evaluate and gauge progress in a way that makes sense. And if you're not measuring that and tracking it, who knows what you're doing?
And with assessments, so much can be said that the devil's in the details, because I know a lot of physicians that do assessment, but the way they do assessment is, someone sits in their waiting room for 5 minutes, takes a 5-question questionnaire, right? And based on that, they consider that to be assessment. Our assessment tends to be more in depth and also utilizing measures that have far greater documentation of reliability and validity.
And I will say one more thing, and that is cultural differences. That, the diet that you eat, or the pills that you take, or the medicines that you take and how you take them have a cultural significance. And I think we as psychologists tend to be, or want to be anyway, more tuned into cultural aspects of ways of moving through this world. And a lot of times that can make or break. I mean, and I'm also taking, the spiritual tonic that my grandma made me, or my diet even is interacting with the medicines that I'm taking. That's oftentimes something that I think we lay claim to, at least knowing it's important, even if we don't always follow through with making it count in our assessment.
This was fascinating. Thank you both for joining me, Dr. Brown, Dr. Sexton. It was wonderful to review the history of a very important chapter in our RxP evolution. And thank you, everyone, for joining us today. And we will see you next time in another episode of the history and continuing evolution of RxP.